This will be a demonstration of a technique I like to call the short leg pull. Most of us are accustomed with some type of a technique where we come in around the patient's ankle, lean back and give her a long leg pull, maybe to move a hip or move a spine a little bit. Can be quite effective, can also be quite a lot of work with the bigger legs in the clinic. So what I like to do is a short leg pull. It's a nice demonstration of either moving the person's knee, moving their hip, or actually moving their spine a little bit in a non-specific sort of way. So I'm going to have her leg bent like so now it's short leg and not long leg. Put my forearm behind her knee in that popliteal area. Then what I can do, if I want to move her hip, for example, now is I'm going to lean away from her hip parallel with the shaft of the femur. So I'm going to pull like so, almost like I'm trying to make her femur longer, right? But you can see now when I do that the skeleton's knee is just extending as I do that. So I'm going to come in and basically block the knee from extending and pull the femur to make it longer, right? I can also take the same exact hand position here, and instead of pulling to make the femur longer, I can just pull parallel with the table and give her a little bit of unilateral traction through her spine. So it's almost like I'll trying to drag her down on the table and slide her a little bit, but she'll feel it in her spine instead. So I can use a very similar technique to move her hip, to move her spine, or thirdly, to actually bend her knee and move her knee a little bit more. So now I'm just using an osteokinematic mobilization, not arthro. I'm going to block behind her knee and basically just flex her knee over my forearm. Again, it's not arthrokinematic, but it's osteokinematic. It's just passive range of motion, but my forearm becomes the new axis of rotation. Instead of being 2/3 posterior in the femoral condyles, my arm becomes the axis, giving a nice stretch because of the increased distance away from the axis to the anterior knee. So let me show you what it looks like on a real person. Put this on the ground. I'm gonna have you bend your opposite leg, scoot a little bit closer to me. Good. Right. So I can play a little bit with what angle I want this femur to be at based on what angle this femur is at. I'll put her kind of in this comfortable position here, right? And I'm just gonna block here. Now if I do the first technique to kind of give her a little bit of hip distraction, I'm just gonna almost lean away and up, right? So I'm trying to make her femur longer. And if I don't block her ankle, you'll see that just extends her knee if I just lean away with my body. So all I'm gonna do with my left hand is block her ankle so her knee doesn't extend, and then I lean away. I'll kind of exaggerate my tipping of my trunk to pull on her femur, right? So the ball and socket joint. You can also add a little bit of rotation. Patients love this. So I'm not only tractioning, but then I can rotate. Again, for the patients that lack that medial rotation, sometimes if you give them a little bit of traction, and then you can do some large fiber input, wiggling here for pain reduction. They say that feels pretty good, right? So that's my hip traction. Again, if I wanted to be a less angle of flexion, I would just drop her opposite leg, make this relatively parallel, and again, I'm just pulling right down the shaft of the femur, right? Let's go to the second part when I do this for the trunk, the spine. Again, it's not specific, but my positioning is exactly the same, but now instead of leaning up and out, I'm just gonna lean parallel with the table, like I'm trying to pull her down on the table a little bit, and she'll feel this now in her spine and not in her femur. So there's no up for the pulling now. Hopefully you're gonna see with my trunk, I'm just starting towards her head and I'm just shifting my weight towards my caudal foot to give her a little bit of unilateral spinal traction manually. Again, really nice technique. Patients like it quite a bit. They get some pain relief pretty much immediately with this. Right? Again, the third modification of this short leg pull can just be to bend her knee. So as long as the patient tolerates this, so maybe not a week out of surgery, but as long as it's tolerable, it's a great technique. So I'm just gonna, same exact position, right? But now instead of pulling on her femur or pulling on her spine, I'm literally just gonna bend her knee, right? And this is my counter force in that popliteal area, creating the new axis of rotation, and I can literally bend her knee around my forearm, right? They should get a nice stretch on the anterior structures in here, and it can be quite effective. Patients often say they think it must hurt the clinician's arm because all the weight of their legs underneath there, but super, super easy to do, super effective. You could build in a little hold relax if you want. So I could say, don't let me bend your leg anymore. and she could kick out gently with her quads. Wait your magical amount of time, and then on the relax, see if you can passively overpress further into it. So 3 nice techniques: hip pull, spine pull, non-specific to a segment, and then thirdly, just the knee flexion mobilization, all with this short leg pull. Thank you.